Chest pain is very important to understand because we know, yeah, in America, CV death is number one on the list of the things that, or the reasons that people pass. And having increased mortality, the number one sign or symptom of an MI is chest pain. So we have something, you have a patient who's presenting with chest pain. Is this a myocardial infarction that's going to end up with heart failure or cardiac arrest or death? Or is this musculoskeletal pain that can go home? So I think it's really important to differentiate. Is this something that's going to potentially kill someone, or is this something that can be worked up as an outpatient setting? I think as physicians, our gut goes into play a lot. And I think most of the times it's a very good thing when our gut and we have a hunch that this is cardiovascular chest pain, or this is cardiac chest pain. But sometimes it can work against us in patients where there's not a high prevalence of myocardial infarctions or cardiovascular disease. Pointedly, young women may not present the same way as men, and going on gut instinct, if you haven't seen that type of patient presenting with dyspnea or chest burning that's a little bit different, your gut may tell you, based on what you've seen before, that this is not cardiac in nature. But sometimes the gut can be misleading. So I think it's really important for all of us to acknowledge that we have instincts and hunches and, implicit thoughts, but be sure that doesn't really affect how we're treating patients. Just because you're not seeing that specific group doesn't mean that they don't have the disease that that comes along with chest pain.